Excellent. Rich Fernandez, how are you?
Very well, thank you.
Rich, how are you? Peter Grape here.
Oh, hey, Peter, how you doing?
I'm good.
Thank you.
Good.
Breakfast, I'm gonna figure out to cook it for yourself because I gotta get ready.
All right, get started. Thank you all for joining us for another series of meeting some of our leading CEOs and the leading organizations on the South Shore. It gives us a chance during this new normal to get to know some of our leadership and the organizations a little bit better. This morning we have Dr. Peter Grape, who built up a substantial practice here with Harbor Medical and a large provider network, which I knew a little bit about, but don't know all the history, and then affiliated with Brigham and Women's, and kind of an interesting model that we're seeing play out. And hope to get in a little discussion. We'll talk about current healthcare issues, if there are any out there, who knows. We'll talk a little bit about the current health issues, but talk a little bit about the evolving health delivery model that we have on the door, and maybe get a sense as to how that looks post COVID and post recovery. But with that, let me turn it over to you, Dr. Grape. I know you've preferred that we all use your first name here, so we'll try to break the habit of formality. But let me turn it over to Peter Grape to talk a little bit about your own personal background and then the network you built up and the affiliation, and then we'll get into the current healthcare issues.
So thank you, Peter. I appreciate it. And thank you, everybody, for joining. And I appreciate you giving me the time. I've actually looked at a number of the presentations, the 40 with Forman, and I've got a high bar here. I'm worried because extraordinarily impressive leadership in the South Shore. And so I appreciate you allowing me to join and be part of it. So let me give you a tiny bit about my background. I won't spend a lot of time on that, and then give you a very brief history of Harbor and then how we ended up with the Brigham. And then I'll open it up to any questions. So I grew up actually in Connecticut and spent most of my my formative years in Connecticut. Ended up going to a school called Trinity College in Hartford, Connecticut, and then immediately went on to University of Connecticut Medical School. So that was up through my early 20s. And then started my training in Boston. So St. Elizabeth's Hospital, I did my internal medicine training, which was 3 years. And then subsequently, I did my cardiology fellowship at a place called the Brigham and the West Roxbury VA. So that was a 2-year stint. And then joined a guy by the name of Richard Whitney, who you may have heard about. He is a physician at the South Shore. And I joined two other doctors, Dr. Whitney and Dr. Merlis, and we formed an organization called Cardiovascular Health Associates. Frankly, at that time, that became the next Harbor. That became Harbor. I think most of the docs at that time, frankly, when they asked who wanted to run the business, most of them didn't. And I enjoyed the business aspects of this, so I kind of took over a little bit. And I don't know how much you know about, and I won't spend too much time on this, but in the 80s, in the mid 80s, you're able to go anywhere you want to as a patient, and we were able to grow independently. And then all of a sudden, this thing called managed care came around and started talking about how we needed to get a referral from a primary care doctor, which hadn't happened before. So we decided to expand into multi-specialty and primary care, and that kind of the rest is history. Over the next 30 years, we expanded our practice to about 70 doctors, and about half of them are primary care doctors. About half of those are family practice. The other half are internal medicine. And then the final half, so the other 30 doctors are specialists, and frankly, all medical specialties. So we have cardiology, GI, pulmonary, neurology, when I say GI, sorry for the verbiage, gastroenterology, endocrinology, so all the medical specialties. And then in addition to all of that, we decided we got involved in a number of ancillary services. So we got involved in imaging, CAT scan and MRI. We got involved in cardiac testing and lab testing and so forth and so on. So I frankly thought I was smart to do all those things, but if you look throughout the country, all these groups were doing this exact same thing. So that got us to the point of about 7 or 8 years ago. And I don't know how much you know about healthcare, but at that time there was a huge, and still is, a lot of consolidation occurring in the healthcare market. And so groups were coming together. There was very little small groups existing at that time, and they were starting to coalesce into larger networks. You know, I felt that our group, even as big as it was, 70, was going to have difficulty in the future with all the capital needs that we had. So we started looking for partners, little p, looked at all the networks, had a long-standing history with the Brigham, and so decided about 5 years ago to join the Brigham in March of 2015. So we became part of Brigham Health at that time. And frankly, it's a marriage of two very different kind of medical groups, but it really kind of melds something that you need in both things. It's very important for us to keep local care local. So we expected to continue to use South Shore Hospital as our primary facility. We continue to do, obviously, our ambulatory work down here. But clearly, if we needed extra expertise, such as, special cardiac work or bypass surgery or other kind of tertiary work, we would use the Brigham. And we had a communication model in which we really could kind of talk to them at any time about certain cases that we had. So over the last 5 years, it's really kind of a marriage made in heaven and really worked well for us. So that's where we've ended up. The Brigham has added a lot to our practice. I'm very excited about it. We added a Hingham office. We built Pembroke and have a multi-specialty practice there. And then we subsequently have expanded our offices in Scituate and Weymouth and in Braintree. So we are open for business. They have added a lot of primary care, which is something that's difficult to get these days. So we have primary care availability both in Hingham significantly, in Pembroke. We have new doctors in Weymouth. So, I think we've really worked well actually with the Brigham. I'm very excited about our relationship. So that kind of gets us to where we are now, and I'm happy to kind of move from there, Peter, and answer any questions. I have a lot I could talk about, so I'll take your lead.
Let me ask, and I should also introduce, for people who may not have the full screen up, but Renee McGinnis, who is our chair of the chamber, is president of Norwell VNA and is on the call with us, and she may with questions as we go along as well, since this is her field as well. But let me ask you a straight business question about branding, because Harbor Medical is a big brand. You built up a big practice here. Brand is important in terms of customer relations and confidence, particularly in the healthcare area. Brigham, while certainly a well-known name, was not as present or familiar on the South Shore. So you got a branding issue there as a business operation. And I think even to this day, 5 years into the merger, it's very tough. I live in Plymouth, and to this day, BID Plymouth is still Jordan Hospital. Rich Fernandez is BID Milton, and I think he goes nuts when he hears me talking about Jordan Hospital.
Peter, you've got to get with it, man. Do you still take taxis, Peter? Or do you use Uber? I mean,
I do take taxis.
Okay.
This younger generation, you millennials, Rich, who keep wanting to the world. It's still the Jordan. I take taxis.
He uses a flip phone too. So.
But let me ask you, Peter, about the branding and the market operation and the names, because the Harbor Medical Group name is still around and still used. So tell me how you do that
Well,
branding.
so I mean, frankly, we co-branded Brigham Harbor. And right now, and we've done that on purpose because we're known well in the community. You know, frankly, I think the Brigham is extraordinarily well known too, and has a reputation that kind of adds to our brand rather than subtracts from it by that matter. So I think that, again, a little bit of people get the expertise and the academic background of the Brigham, but also know that they're coming to their local place, and all healthcare, and Rich will tell you this, all healthcare is local. It's very, very important that you have that local presence for people, because that's what they want. They want to know their doctor, and they want to get to know their doctor well. And I have patients that I've known for 30 years. They're more family than they are patients these days. And so I think that's extraordinarily important. I don't think we've lost that. I think patients still feel that, but they also feel the ability, if they need to be able to get the expertise into town. So I think we brand ourselves as kind of Brigham Health, Harbor Medical. So we use both brands, and I think that's frankly worked for us. And I suspect some point, you know, the Harbor, I don't know what will happen to Harbor, but Harbor may, the name will go away. It's funny, I don't feel strongly about it, to be honest with you. I think the Brigham Health brand is something that I'm very proud of, and I think people would be very, very happy to go to, because it has such a huge reputation throughout the country. So
yeah, jumping in on that, Peter, and Peter Grape, and then Peter Forman, to your point, is I do think generationally there's something going on in that people do they want their care local, but they do want to know that when they need care in a tertiary hospital, it's going to be one of the best. So I think it's very important for people to know, which I think, you know, helped South Shore in that, you know, people know, okay, if I belong to Harbor Medical, which is the biggest practice down here, if I need tertiary care, I'm going to go to the Brigham, and I feel good about that because I know, you know, they have the cardiology, all the things that they can get there. I think it is almost a generational thing, though, when you look at people that are under, even the baby boomers, they want to know that they can seek the best care when they need it. So I do think that's an important branding that's gone on for generations to come. So, yeah.
And frankly, the Brigham has a significant affiliation with South Shore in many different ways. So they're most of the surgery department, they're the trauma, they are their neurology department to a certain extent. Their cancer center is Brigham. So the hospital is significantly affiliated with the Brigham, you know, which is some challenges for the hospital going forward. But frankly, that affiliation has helped us. But I mean, it's extraordinarily important to tell the patients we expect to keep local care local. So if the patient really, if their care can happen at South Shore Hospital, that's where we expect it to happen, despite the lack of complete affiliation between the Brigham and South Shore. But frankly, we have a number of expertise. So we have a cardiologist from the Brigham that comes down, a heart failure specialist that really helps us with our very difficult patients and kind of guides us through very sophisticated care that otherwise wouldn't necessarily be immediately available. So I suspect as I said, we have the ability to kind of tap into a level of care that doesn't really exist in a local setting most of the time.
Let me ask you about the staffing. Harbor Medical is a little unusual because of the large concentration of general practitioners and pediatricians, and you merged at about the time that I was hearing that people were maybe steering away from the general practices, getting more into specialties because of reimbursement. How has that world changed? And did the Affordable Care Act make it a little more attractive at all for general practitioners and pediatricians, the schools doing more with that? Or are we still struggling finding trained physicians for those general areas?
So the answer is there are difficulties. There is challenges in recruiting primary care, and we've experienced those. Although again, I think the Brigham brand has helped us in that. But yes, I mean, I think physicians are tending more towards specialty services because of reimbursement and because of compensation. But on the other hand, we have been able to, again, a little bit because of the Brigham, and been able to adequately compensate the primary care doctors, and because of the brand, able to attract them. So we have 4 or 5 new primary care doctors that have joined us over the last 2 years. And frankly, I think most of these networks, and Rich will kind of validate this, primary care is extraordinarily important, that we are able to kind of embrace any number of what we call covered lives and be able to have as many primary care patients as we can. So it's extraordinarily important to all the networks that they embrace and grow primary care. So it's a little bit of both worlds, Peter. In other words, the doctors are gravitating a lot more towards specialty care. So it is a challenge for recruitment. At the same time, the networks clearly want primary care and are willing to kind of support that to make certain that we have enough primary care available for the area.
So with our economic work, we have to look at workforce and recruiting businesses and how the South Shore competes with the rest of Mass and the rest of the country for people. How does the South Shore rank with attracting primary care physicians, and what's the secret sauce you and Rich and Renee use to recruit healthcare talent to the South Shore? Is it the quality of life or the strong network of care that we have down here?
So I think it's a little bit of everything. I mean, frankly, it's not, compared to other areas, it's much easier to recruit in this area because you have communities that people want to live in, the education, the business, the kind of, it's a very robust economy and a very robust area. So it's a very attractive area for people to live in. And so that's not much of a challenge. The nice thing is we have not only that, but also have the docs can kind of affiliate themselves with the Brigham. So they feel yes, they're local doctors and do local care, but they also have the academic credentials of being part of the Brigham. And so that's a plus. So we don't have, I think comparatively, I mean, I think everybody has challenges in recruiting primary care, but I think relatively we have a little bit less challenges because the area is such a wonderful area to attract people to. So I don't think we have much challenges from that respect at all.
Yes, it was lost a little bit because of COVID, but the Baker administration was working on some healthcare initiatives this year, 2 of which I thought were going to be pretty transformative and interesting. One was pumping more reimbursement into the system for telemedicine, and the other was pumping more into for mental health issues, both of which I think were really important at getting at a lot of concerns about access and costs. How is that playing out? A little hard to measure it, I suspect, during a pandemic with the shutdown, but how are those panning out? And particularly with family health care, what is going on with lower threshold mental health issues during the pandemic?
So let me talk a little bit about telemedicine first. So Baker, no matter what he did with respect to it, there's nothing that could be better for telemedicine than the COVID. I hate to tell you the COVID did it. He didn't do any reimbursement whatsoever. The COVID transformed us into telemedicine. I think Rich will confirm this as well. So effectively, let me give you some of a sense. We traditionally saw about 3,000 patients a week in our ambulatory setting. So face-to-face with a provider throughout their entire organization, saw about 3,000 patients a week when we were full running. That's around 600 a day, 5 days a week. So when the COVID struck, our face-to-face visits went down into the dozens. So from 600 a day to maybe a dozen a day face-to-face visits just because of COVID and trying to keep people away and protected and so forth in a safe environment. And what happened was we pivoted to what you call telemedicine. So initially it was phone visits, which the state actually reimbursed us for. And then we have subsequently transformed ourselves into video visits from there. So we were doing over 1,000 of these telemedicine visits a week, when we were doing almost none before COVID. So we completely transformed our care into the telemedicine area over the last 3 months. And that's not going to go away. So to kind of, again, talk about telemedicine, a portion of our practice is going to remain telemedicine and video visits for patients going forward, even as we start refilling our clinics with face-to-face visits. Now, behavioral health. I think South Shore is doing a tremendous job in adding behavioral health. We do not have, our practice in particular, do not have significant behavioral health people. On the other hand, we tap into the Brigham, and they have a very robust psychiatry department, and which is just perfectly fit for telemedicine. You know, they're, frankly, as other practices such as orthopedic died out with the COVID crisis, psychiatry department blossomed in the telemedicine area, simply because patients could, felt comfortable in a telemedicine kind of environment in a psychiatry fashion and behavioral health. And so we're, again, pivoting to telemedicine for behavioral health, and that's been extraordinarily a positive experience. So both of those things are, frankly, a product of COVID as much as anything else, and it's been very successful. So it's been good.
Interesting. About 20 years ago at this point, I was sheriff of Plymouth County, and I introduced telemedicine to the Plymouth House of Correction. I think we were the first House of Correction to use it, connecting to Shattuck. For us, it was partly an efficiency and safety issue to not transport people up to Boston. And the technology was fairly primitive compared to today, 20 years ago. But we found that the inmates actually responded really well. And it wasn't over the medical care as much as the psychological impact of feeling they were getting more attention and were getting some sort of special treatment by being able to avoid the hassle of transporting up to Boston. And so what little experience I had with it, I found that for the mental health aspect, far less stressful, far more personal in many ways than the face-to-face visit, or at least the result was. So.
I mean, the challenges we have are frankly in kind of getting the technology through. So we have to teach our providers how to do it. We have to teach our staff how to get it prepared, and then we have to teach our patients how to do it. So there's a lot of work behind the scenes in order to become successful with it. But we've had a tremendous amount of experience over the last 2 or 3 months, and I think we've started to get it down. And I think that it's clearly something that's going to be part of our armamentarium going forward, where it wasn't before. So the COVID really has made a major difference in that kind of care. And it's been good. We find it's very successful, and patients like it.
And
Peter, can I ask
jump on that, Peter, and Dr. Grape knows this, we work closely with Harbor Medical with our telehealth program, and we were assisting them during this time, all our physicians during this time, to help them teach the patients how to use even if it's FaceTime. So there's a lot of education that goes into teaching the patients, especially the frail elders, if they don't have a caregiver in the home. But, Harbor's been very progressive in looking at these palliative patients and how do we keep them home and out of the hospital. So we've been working closely with them on that initiative, which really came to fruition during COVID because people did not want to go to the hospital. So we saw a lot of patients, choosing hospice and choosing not to go to the hospital when, they would get the benefit. So I think it's helped people to understand what is the benefit of the palliative program and staying home with all the support that we can give them. and Harbor's been really at the forefront of this, working with us before COVID. So I think it's been a great initiative, and the telehealth and the virtual visits just help support all patients' anxiety and stress, and doing those telehealth visits, I think, is huge. So
yeah, and Norwell VNA has been phenomenal in this. You have a gem here down here with Norwell VNA in the South Shore. You should be very proud of them. They've done a phenomenal job both in that arena and in the care of patients down on the South Shore. We're very lucky to have them. So thank you for everything you do.
Thank you, Peter.
Who else was trying to jump in? Was that Rich or?
That was Chris.
Chris.
I'd love to ask a question. Good morning.
Hi, Chris.
Hi. So first of all, a little about patient testimonial. Harbor Medical has been taking care of me and my wife and my family for 20 years, and really wonderful experience. So thank you, Peter.
You're very welcome.
So telehealth gets all the attention as sort of the major learning from COVID. I imagine that there are other learnings and sort of imperatives that or ahas that have come out of this crisis. What else have you learned, has the medical community learned that we can sort of utilize or do even better going forward out of this crisis?
So, I mean, it's been a major transformation. I mean, you can't imagine what the healthcare community, I'm sure all these businesses have felt it, but the healthcare community by far has been just totally transformed. So when we started in March, we were seeing almost no patients. And at the same time, all these hospitals were building up in expensive kind of care, and yet there was none of the kind of revenue that they had expected. So we had gone to almost no face-to-face visits, and over the course of the last month or so, have started bringing patients back. And what's most extraordinarily important is that we have the safe care commitment, that we commit to the patients that we are doing whatever we can to make sure that they're safe as they come back into our clinics. So it's required three major things, and I'm not sure these are going to end anytime soon, Chris. On my sense of things, these are going to go on for quite a while. So we mask everyone. So not only the patients, but we mask the providers. So everybody's masked. We also screen the patients. So we not only screen at the time of the time they make their appointment to make certain they don't have COVID symptoms or any of the issues that put everybody else at risk. We also screen them 48 hours before they come. We screen them in the building entrance, and finally we screen them at the front desk to make sure that we're all safe when they come. And then finally, we do a lot of spacing. So our exam room, our waiting rooms, if you look at them, have half the number of chairs or even a third of the number of chairs they used to have. We've started putting plexiglass barriers. Plexiglass business must be going through the roof these days because you should be buying plexiglass stock if you can do it. But we've been getting plexiglass throughout our organization so that we can create barriers to patients in which we can't keep them 6 feet apart. So it's extraordinarily important to us that the patients feel safe. And my guess is that's not going to go away anytime soon. I think that's something that's going to be around for a long, long time. And so we not only have to keep our patients safe, but we have to keep our staff and our providers safe. So that's been a very, very significant part. And the beauty of the Brigham is they have the experience, again, the depth and the breadth to be able to guide us through this. So they've been able to help us with all of that too. So it's been a good experience. I suspect going forward in the future, those kind of things are going to continue. Some of the masking, some of the screening, some of the spacing will all continue. And then I think that we're going to be utilizing telemedicine a great deal more in our healthcare environment than we had before. So all of those things will be a significant part of our environment. I think the most important thing is we want to keep local care local. I think the patients really, really develop a significant bonding with their primary care provider. That's the person they trust. And so but the beauty of our system is that because Harbor Medical has so many different specialties and we can tap into a tertiary facility, the patients are always kind of going within our system. And I think they feel good about that. So when we send them to a specialist from a primary care doctor, they're going to our specialist and they feel good the communication is there. Frankly, and the last thing I want to say is we communicate with our EMR system without referring. So I get a patient that has a thyroid issue that say, oh gosh, what am I going to do? I will text or message the endocrinologist saying, this is the problem I have. What do you think? And they'll say, do this and this, and then let me know, or I need to see the patient, and so some of this stuff occurs without any kind of referral or frankly cost from the patient part, because we're able to communicate with each other about various different problems we have. And I get that from primary care doctors all the time for a cardiology question they have. And we manage some of that just simply on the electronic medical record. And I suspect that will continue as we move forward too. I talk too much.
No.
Thank you.
Peter, do you still practice medicine?
So I do. I see patients a couple of days, couple of afternoons a week. Again, most of these are patients that I've taken care of for many, many years. A number of personal situations in which they're really part of my family. I feel they're part of my family. I hate to say I used to hug them, but I don't do that anymore when I come into the exam room. And I think they feel that I'm part of their family too. So, and it's, many of these patients had heart attacks, 20 years ago, and obviously continue to have heart disease. It's a chronic issue. So I managed them over the years, even though I first saw them 20 years ago with their first heart attack, or helped them with their heart failure when they first presented to me. And hopefully, the most important thing is to keep them so they're able to do their activities of daily living and continue to do the things they do. So yes, I'm limited in my practice, to answer your question. I see patients 2 afternoons a week, and not a lot of new patients, but a few new patients. But
I want to ask about you as an organizational leader. But before doing that, do you miss practicing? Has it been a good trade-off for you personally to do more on the administrative side?
Yeah, I mean, I like both, to be frank with you, Peter. I enjoyed the business aspect of medicine. It's funny, when I was in college, I applied to both business school and medical school, and I got into Wharton and I made the wrong decision. I went into medicine. No, I'm only kidding. But I frankly got the best of both worlds. I enjoyed the business aspect. I enjoyed growing our organization to where it is today, and felt a sense of accomplishment of that. But at the same time, I have a very significant relationship with these patients, and I feel very, very close to some of them. Frankly, I hate to say it, but most of our patients are over 85. Most of my patients are, because they've been with me for so long. So it's very hard also when they pass, and unfortunately they do. And it's a very difficult situation for me too. But so I enjoy both aspects. I enjoy the care, but I enjoy the business too. So it's both have been good for me. And I will continue the care for a while now. So it's been good.
How did
Peter, can I sneak in a question real quick?
Sure.
Just want to comment, and when the gentleman asked about kind of what's new, and it kind of gets back to, number one, I know we're talking about different generations, but I look at telemedicine, I totally agree with Peter. This is here to stay, and it shouldn't have taken this long. This is like going to the airport and going to the check-in to get your ticket. I know Peter may do that, but even the kiosk,
Peter Forman, please.
it on your phone, but there is no reason. I mean, this is like the COVID, unfortunately, aligned the payers, the patients, and the providers to just make it happen. And unfortunately, in healthcare, that sometimes, unfortunately, it took a pandemic to do that, but it is definitely here to stay. And I would just say, and I think I said it last week or when I was on, we need our employers and everybody to talk to their insurance and others to put pressure to do this and ask for it, demand that you want it. It's not for every visit, but absolutely, this should be like a benefit that large employers or self-insured should be able to demand. We can't let this one pass. But the other thing I think we've all learned, and I'd be curious to hear what you're doing at Harbor, is around testing and having the infrastructure, literally people, facilities, machines, swabs, everything. That's a whole new business line to keeping us safe and testing in the public good. So, Peter, at Harbor, I know a lot of hospitals, we've set up testing, and have you guys started to do testing at your sites and or have partnerships with others? And are you looking at doing testing in-house at your sites? You have the size and the depth to probably make it worthwhile. But I'd just be curious of how you're looking at that as a large group attached to a big system, but the big system's 20 miles away in Boston.
Right. So yes, and I haven't talked a lot about our COVID response, but when we first experienced the COVID, we closed our Hingham office and our Situate office, and we concentrated our patients basically in Pembroke and Weymouth. We created what we call a respiratory illness clinic in our Pembroke site, which you could enter from the outside. And so we concentrated any patients that had respiratory symptoms that were possibly COVID positive. And I'm going to get to the testing in a second, but we concentrated those patients into a single place where we could see them with significant personal protective equipment and make certain that we cared for them there. Frankly, we tried to keep most patients home if we could. So that was transformative to our practice, and we're slowly getting back to what I would call a new normal, in which we are closing those clinics and opening up our urgent care and our walk-in centers, which we had closed before. Now, testing. So we opened up a tent in Pembroke. So we continue to test all of our patients in a drive-through tent in Pembroke. And frankly, it's been quite busy because, as you know, Rich, people are starting to come back for procedures and for surgeries and so forth. And all those things are requiring testing beforehand. So we're actually testing a lot of MGB, the old partners, the Mass General Brigham. We're testing a lot of patients throughout that organization down in our Pembroke office in order to be ready for the procedures and surgeries. And then I think we are starting to do some testing in our urgent care sites. So we're going to test specifically in urgent care. Testing, as you know, requires a lot more equipment and a lot more care. So we want to concentrate it on places in which we can do it right. And so we are going to test in some of our urgent care sites as well. But we've been testing for the last several months now. And I think we have the ability to do serology, but frankly, we haven't embraced that yet. I mean, I think the Brigham has, but we've been doing mostly the nasal swabs and so forth. I think that answers your question. And we're going to continue to do it for a while, I think.
Let me ask you a little bit about organizational leadership. How did the affiliation change you as an organizational leader, and how has COVID changed you as an organizational leader?
Well, I got a boss for the first time, which I didn't have for 30 years. I mean, don't misunderstand me. I reported to the shareholders of the organization, and as such, I felt responsible for them. But to a certain extent, I didn't have a single person as a boss until I joined the Brigham. That's been a positive experience, though, and they have a lot of depth and breadth and have helped us a great deal in terms of the resources that we need. But it's changed. I'm no longer kind of doing the other thing is we moved pretty quick for the last 30 years. When we decided to do something, it would take a few months to kind of get it up and running versus having to think about it for a year before we did it. So those things have changed. But frankly, we had really matured as an organization. So most of the things we wanted to do, we had already done. So that it wasn't a big barrier for us. I think the big thing that the Brigham has added a huge number of resources that we otherwise didn't have. They built the Hingham office, they built the Pembroke office, they've added primary care doctors, which frankly, getting back to primary care, it's an investment. They create they lose a lot of money, frankly, in the very beginning. So you have to be able to invest in them. I wouldn't have, as a private company, been able to do that at this time, but Brigham has been able to give us the resources to add the primary care doctors to both Hingham, Pembroke, and Weymouth. So that's been a very positive experience. And so from an organizational point of view, I found that it's something that I was ready to move on and ready to move on to a bigger organization that was able to add the resources that we needed to be able to grow to what we wanted to do. So it's been a good thing. I've enjoyed that. And COVID, they've added a huge number of resources for us with COVID. I mean, so in other words, they have the depth and breadth of infectious disease and environmental protection expertise and so forth to be able to really guide us through the COVID crisis in a way that, and they frankly have done this throughout their whole organization. So we're following guidelines that they've created throughout Mass General Brigham, and so it's been a very positive experience in that fashion too. We were looking forward to opening up. I mean, we're seeing about 60% face-to-face of our normal volume now, and we expect by August to see hopefully about 100% of what we normally do, as long as we can keep everybody safe moving through our clinics. So that's going to be extraordinarily important. And the Brigham helps us with doing all of that. So we're open for business, and we hope to get, obviously new patients to our different sites and get people feeling comfortable coming to a safe environment. And frankly, we thought, we were scared, and I think other businesses are too, that we were going to have trouble getting people back, but patients want to come back. They want to see their docs. They want to see them face to face. So that's been a good thing. It's been working.
So 60, and you're what'd you say, 60 now? I hope to get to 80 in August.
60%. We hope to get to about 85% normal face-to-face visits in August. And the other 10 or 15% are going to be telemedicine visits. So there's going to be probably, I'm going to say 100 telemedicine visits a day, something to that effect. And then maybe 500 face-to-face visits a day as we move forward.
That's in provider. Let me ask Rich and Renee, what are your percentages for a hospital and then for home site care? What are your percentages up to now?
So, I mean, the hospital, different units, but our overall discharges are back up to like 85% of what we were expected. Our ambulatory areas are actually much closer to 90 and 95%. So everything is coming back. We were very I think everybody was a little pessimistic about how quickly, and we've been pleasantly surprised with that. And I think we're just getting our primary care docs back in the office too, which to me sends a message that it's okay to come. I mean, we've locked people down for so long. If your docs aren't in the office and your PCP, something's got to be wrong. So we've made a concerted effort over the next 6 weeks to really get our primary care back in the office. And again, doing the combination of virtual and in person. I mean, it's pretty hard. Peter will tell you to do a physical without touching the patient. I'm not sure. If I were an insurance company, I wouldn't pay for that physical either. So,
Yeah. Well, and for us, of course, we lag a little behind Dr. Grape and Rich because that's where we get our patients. So once they're 100% and 80%, we're probably right now about, my team is on here, but 75%. So we're getting those patients that delayed their elective surgeries and the physicians are referring. So we're hoping to be by September, October, back to 100%.
And we're starting to refer our patients out to systems that make certain that they're safe and so forth. So I think the system is starting to get back to normal. And I suspect the next 2 or 3 months, it'll be back to where it was, with the exception that telemedicine is going to replace a certain percentage of the visits that didn't exist before. And to Rich's point, that's a very positive event. So this has been, it's been good. But our Hingham offices and Situate office, which were closed, are now back and open again. And so we're seeing patients in those offices as well. So it's we're back to business.
So your affiliation, I think everyone intuitively gets the benefit of being able to partner into higher level resources and those teaching hospital models. What about going down the scale into more community-based services, the allied health fields? What does that infrastructure look like on the South Shore? We've been hearing, we're thinking a little bit at the chamber that there's workforce issues in the allied health field, and being able to do things like home health care, nursing homes are going to be impacted by this. But how do you think the South Shore compares to other areas for some of other levels of healthcare treatment?
Yeah, I don't think we experience a lot of difficulty moving these patients through those kinds of systems into home health and into the nursing facilities. Frankly, there's probably a little bit too many nursing home beds in the South Shore, although they have been contracting a tiny bit over the last few years. There's still probably a few too many that we have. you know, we have to make certain that as much as possible, we keep our patients in an ambulatory setting and away, frankly, from the hospital unless they absolutely need it, and away from the nursing home unless they absolutely need it. So we're working very hard, and particularly with the home health people, to be able to keep people in their homes if at all possible. That's extraordinarily important to us, and it's a new paradigm that frankly we need to kind of make certain that we pay attention to, and we are kind of insisting that we work it's hard, but we work very, very carefully to kind of keep our patients as much as possible at home. And frankly, I think the allied health professions are sufficient enough to be able to do that. So we haven't experienced any difficulty with them at this point. I think we find that they've worked pretty well for us, and we're doing okay with that.
Where do you think we have gaps on the South Shore? Is it in behavioral health? Is it in a high-end specialty area?
You know, frankly, South Shore, you should be very proud of South Shore Hospital. They've created a significant level of care that is over and above most community hospitals, in the sense that they have, significant neurosurgery depth, trauma surgery, cancer care, that you're not going to get those kind of levels of care in other community hospitals per se. Now, Rich's Hospital is able to tap into the BI Deaconess system, so he has the same kind of levels of care he can do. South Shore Hospital does a lot of that at South Shore Hospital. I don't know, and I think where you can't do that, we move those patients into Boston. I frankly think that there isn't a lot, with the exception of behavioral health. That's probably the area where we need to get into the depth and the breadth of behavioral health. That's an area that really, really needs to be concentrated on, and we need to too. And so, you know, that's something we are looking at very closely, and how we're going to move through that, because that's going to be an area that's very important going forward. And I think that the hospital, South Shore Hospitals, realize that and is developing systems to do that as well.
So in addition to the Chamber Board, the Chamber has an Economic Development Corporation. Rich Beal, who's on the call, chairs that. We're spending a lot of time at the Chamber looking at the region's competitive health, competitive advantages for economic opportunity. Healthcare as an industry sector is probably our largest employment sector on the South Shore. But there are a lot of changes going on in healthcare, as you know, and that will affect the area. But we think healthcare is a good calling card to attract people and businesses down to this area. But how does the business community help support or drive any of the healthcare needs? How can the business community be helpful to the healthcare industry?
So I think make sure, frankly, make sure your employees stay local if they can with their care, and not necessarily. I mean, there's some patients who go into Boston for their care. I don't think that's necessary. I think we can supply as good, if not better, kind of regular primary care and local care local. So I think, making certain, if at all possible, your patients are aware that we exist and other ambulatory areas exist, so that they can support that as well. Healthcare's got a lot of challenges going forward. I mean, it's getting more and more expensive, and nobody's trying to figure out how to pay us more. They're all trying to figure out how to pay us less. So there's going to be major challenges going forward in the healthcare community as they contract the payment systems for us. So, lobbying us to be able to continue the payment systems that they have. But on the other hand, Peter, we need to be responsible with that money that we get, and I think we need to be very more custodians, better custodians of the kind of revenues that we get, in order to be able to make certain that we're spending them the right way. There's been too much in the road, down in the past, of not necessarily being good custodians of the money that we get. And I think we're working very hard to make certain that we use that money responsibly. But we're going to need to be able to continue to increase. I mean, the problem is healthcare is getting more and more complicated. It's getting more and more sophisticated. The medicines and the technology is more and more expensive. And so there's a lot of challenges going forward with respect to being able to help pay for that. So it's going to be a challenge. I don't know how you're going to be able to help us, but you can give us some money if you want. That will help us.
We don't have any money, but we're broke. But I think one of the things we talk about with the 2030 economic plan for the South Shore is, you know, making it a attractive place for people to want to live and be able to afford housing and have the sort of downtown areas that the younger people are looking for, so we can attract talent. So, you know, it's desirable for people to live here. Of course, you've seen a shift with COVID. Any of the realtors on the call will tell you that the residential housing is booming because people want to leave the city. Whereas we were seeing before COVID that everyone wanted to live in the city that was below the age of 40. So now they're moving out to the suburbs. So, but we do have to look at affordable housing and how we can attract people, because it is a very expensive place to live. So that's something we're working on.
You know, I think we have to concentrate on preventive care. We have as a responsibility as medical providers to insist and be able to help patients with their general health care. So, you know, obviously exercise regularly, watching the smoking, watching your weight and so forth. We need to be more responsible in making sure that patients are paying attention to those kinds of issues, because they are major issues going, you know, in terms of ultimate health risks of patients in the future. So, yeah, we have some responsibility there, and I don't think we've done as good a job as we should do on that.
Bernie, did you have a question, or were you trying to flag me? I saw something come up with your name, and I can't find.
Oh, thanks, Peter. No, Peter, I'd love to ask you a question. Do you see any changes exactly on the topic you just mentioned now with COVID? People are eating home-cooked meals more. They're probably walking more. They're not driving in their cars more. Are we seeing any positive benefits that people are paying more attention to their health and diet? I know there's probably mental health issues with people being trapped, but especially on the South Shore where most of us live in single-family detached homes, are we seeing any positive trends that people are starting to eat healthier and you know, have less medical needs?
So I think it's anecdotal, but we are seeing people, you know, people get out more, walk more. It's amazing. You know, it doesn't take a lot, but some of that stuff and the healthier eating, you know, not eating out as much and making your food at home. So, you know, again, it's mostly anecdotal. I don't think there's any kind of studies that have looked at this, but I would suspect that there's been significant, some fairly uptick in a change in the behavior of people that have been a positive aspect of the COVID in that sense. So I agree with you. I think it's been a good thing that way.
Bernie's wife is a nutritionist, actually wrote a book on this. I've been reading and eating more during this. I've added 8 pounds and finally went through the pile and found Silky's book the other day, and I stopped reading.
You stopped reading or stopped eating?
I stopped reading because I didn't want to.
Well, you can eat as much as you want as long as it's healthy. That's the point.
That's right.
Yeah.
If you eat super healthy, nutrient-dense foods, you don't crave a lot of extra stuff. You just eat good stuff.
Yeah. Well, I don't. Particularly this, I was getting out walks, but dropped a full propane tank that rolled out of my car the other day on my foot. So I haven't moved the last few days.
Ouch.
So you'll be proud, Peter. I did not go to an emergency room to get an x-ray to see if I broke a toe or not. I just figured I'll live with it. So
yeah, there you go. We're using the emergency rooms much too much, and that's why we developed an urgent care walk-in, which right now is by schedule, but pretty soon it'll revert back to walk-in. And we're trying to divert people from the emergency room. It's a very expensive place for care, and so we need to kind of get people away from that if at all possible. That's one area that South Shore is working hard on, and we're trying to help as well. So I think it's a big issue.
Excellent. So your political advocacy, just to get back to that, focused a little bit more at the federal level, you think, with issues around ACA and reimbursement, or at the state level? We are following with the U.S. Chamber some talk about federal aid under a phase 4 or phase 5 relief bill for some of the large mega systems that feed the economy. And those are state and local government, healthcare, and the tourism and travel industry. Where would you like to see the business community's advocacy work focused?
So I kind of agree with Rich, is that we need to kind of support the telemedicine program. I mean, the reimbursement of those have been significantly down in the past, and I think we need to kind of bump those up and make certain they're reimbursed at a level that makes sense for us to continue to do them, because I think those are areas that I think are extraordinarily important to kind of concentrate on. You know, the healthcare community is going to need a lot of help going forward. They've lost a great deal of revenue in this crisis. So I think that the hospitals were going to need some shoring up, because I think they've spent a huge amount of resources and they haven't been able to get the kind of revenue to be able to support those resources. So I think the government and the community needs to help support the hospitals. I think we're doing a little bit better than that, in the sense that we're opening back up, and we're able to kind of renew our revenue stream. So I think that's been a positive event. But I think the hospitals and the network and the health systems are going to need some significant help going forward and support to be able to kind of survive.
Great. We're coming up on the hour. As we always do, we go well past the 40 minutes. So I don't know how we branded these 40 minutes with me, maybe because I speak 20 of the 40, of the 60. But
The alliteration, the 40 with Forman.
Yeah, so we got to change that. But we're coming up to the hour, so let me just quickly throw it out to see if anyone has a last-minute comment or a question. Don't want to end this if people have questions on their minds. Great. With that, Peter, thank you very much.
Thank you, and thank everybody. I appreciate the opportunity to talk about us. It's a lot of fun.
Excellent. Stay in touch. Let us know how we can help. We appreciate the engagement.
All right. Take care now.
All right. Thank you all. We'll do it again next Tuesday.
All right.
Thank you.
Thank
Great to see
you.
everybody.
Bye-bye.
Thank you, Peter.
Bye.
Bye.